right, thank you for asking me. It's a pleasure to be here. It's hard to follow Jaime, and especially since he learned to talk so fast, so I'm not going to talk as fast as Jaime did. And I think that my talk is a little bit different. There's certainly some science in there, but there's also quite a bit of rhetoric. When I was putting this talk together was, I guess, 3 or 4, maybe 5 months ago, when we were first putting together our program. And so some of the hurdles that we faced, I thought I should share with you so that you can face them as well when you put it together, your program, if you choose to do these. All right. Okay, so just kind of a little bit of a brief balloon history. I missed the very first part of Jaime's talk because I had a heart attack up in the slide prep room because they didn't have my slides, so I had to run over to the hospitals and get it, or run over to the hotel and get it again. So he might have touched on this, but the balloon, actually, Louisville, which is where I'm from, has a strong heritage in balloons. We were at the university in 1980s, the late 80s. We put in a lot of what was called the Garen Edwards bubble, and it looked like a little soup can. You can see it there in the stomach there. It was sold to doctors for $400, and it cost a patient $3,000. And like the balloons of today, insurance did not cover this procedure. So the New York Times ran an article, and this is where I read it, in 1986, and they were talking about how doctors were making huge bucks by charging $3,000 to put in a device that they had purchased for $400. The problem with the bubble was in 1988 it stopped because of a high complication rate, and it was actually withdrawn from the market 4 years later. There were very high rates of deflation. This was filled with air instead of water, and it had sharp edges, and they felt that was one of the reasons that it deflated. And unlike the balloons today, when it deflated, oftentimes it did go ahead and cause a bowel obstruction. And again, unlike today, when they had that bowel obstruction, they couldn't just put a little laparoscope in and make a little hole and take it out. They had to do a laparotomy to take it out. So all these things were pretty unpalatable for the patients and the FDA. It also had caused a lot of ulcers. We didn't have the same medicines that we have available now, so it didn't really work so well. In 1987, as a result of this, there was a Tarpon Springs conference, and many of you all have heard it referenced whenever it's hard to read a paper about intragastric balloon without reading the Tarpon, or seeing Tarpon Springs, which is, as you can see, the sponge capital of the world. I don't know why that is. But so what the researchers, they met and said, well, how can we make it better? What would the ideal balloon be if we were going to proceed with this in the future? And a lot of the characteristics of the balloons that are now available on the market share the recommendations of the Tarpon Springs Consensus Conference. And they said that the device should be properly leak tested. You should do an endoscopy and look at the upper GI tract before placement, make sure there's no contraindications. The physician should actually be a qualified endoscopist. They should have proper training. You should be able to look at the device before you blow it up. With whatever you blow it up with. And at the time they recommended H2 blockers. We now use proton pump inhibitors. And it needs to be part of a program. And all these things are really true today. They looked at what they felt would be an ideal balloon, and they said, first of all, it works. It doesn't produce a whole lot of ulcers. And you heard Jaime talk a little bit about the reshaped balloon and how they changed their technique and management to decrease ulcers, which is always a problem. It needs to have a radiopaque marker. One thing that it does need to have the ability to be adjusted to a variety of sizes. They felt it would be better, and it probably would be better, to be able to do this after the fact, after it's been in a couple weeks, and you say, well, this maybe isn't big enough, or maybe this is too big. We don't have that ability just yet. It should be constructed of materials to enhance long life and have no sharp edges or ridges. And so the Orbera balloon that I was asked to speak about share many of those things. As you can see, it has no sharp edges. It was previously known as the Bioenterics Intragastric balloon, or BIB. And in fact, if you put many of you I've seen the audience I recognize are putting balloons in, but if you put in a balloon now, even though it's the company that owns the technology is called Apollo now, it'll say Allergan on the top of it, because that's the company that previously owned it. I guess they had a bunch of them in stock, or they just didn't change the mold, I'm not sure. But it was approved for use in the U.S. in 2015. It's designed to be put in for 6 months to help people lose weight, and the fill volume can vary. I've been told that you could probably put 2 liters in before it would pop. You don't want to do that. But approximate fill value is 600 cc's. One advantage, or one thing to bear in mind, I guess you could say it's an advantage of the bib/Orbera, is that it was studied by the American Society for Gastrointestinal Endoscopy Technology Committee, and one of the things that they want is to be PIVI established, and it was that. They felt that it was an effective and reasonably safe alternative to, say, for instance, surgery and or diet alone. And they made this determination from a meta-analysis of 754 citations. So one of the differences between the 2 balloons is there's a lot more data out there because the bib has been bib/Orbera has been available internationally for some time. And the interesting thing, from 754 citations, they managed to use 82 of them to get their data. And when they looked at that, they really drilled all the way down to 17 studies after they had discarded, duplicate studies and duplicate data. And the 12-month weight loss was 25.4 with a confidence interval, 95% confidence interval between 21 and 29. And interestingly, the mean difference in weight over controls was 26.9. So that basically, if you look at it, sometimes you start looking at these figures and they all kind of run together, and you kind of think, what does it really mean? It kind of reminds me of what was the movie, and they said 60% of the time it works 100% of the time. It's kind of what I look at when I see some of these. But basically, if you read that, the control people gained weight if all the meta-analysis data would merge. If you're going to put these in, your patient selections of body mass index between 30 and 40. Now, this is one of these things where it's going to be a real slippery slope. Once you start putting them in, everybody comes in and asks for them because they've heard about it on the radio or in the news or whatever. So somebody comes in with a BMI of 28.5, and you say, well, should I put that in? And you look at them and they say, yeah, it looks like it would help them. They have high blood pressure, and they say they have sleep apnea. And so it is going to be a bit of a slippery slope. What about the young lady who's about to get married, or the guy who's going to his college reunion or high school reunion? He's got a check and he signed it and he's trying to hand it to you, and you got to decide whether you're going to do it or not. And again, anything below a body mass index of 30 is going to be off-label. The second thing that you're going to have to decide is how much you're going to stretch the rules, because in the directions for use it says the patients who qualify this have had no previous esophageal or stomach surgery. And so when I am given the information session to the patients, I say, well, one of the very first things I say is, who can have one of these? And I say, well, if you've had a previous gastric bypass or sleeve or band, and you had good weight loss and then you've regained weight, and you're looking for the next thing, can't have it. No, and you just hear kind of a groan in the room, because that's what everybody's come in to see, because they kind of want the next great thing. One of the reasons, and I'll touch on this in just a little bit, that it is recommended not to put one of these balloons in somebody who's had previous gastric surgeries. That's where the deaths have come from in the studies. People have had previous Nissens, especially. People have had gastric resections for whatever reason. So I'm sure people are going to do it. In fact, I had somebody call me last week and say, really, you mean you're telling me somebody had a band and you took it out because it slipped or whatever, and you wouldn't put a balloon in that person? And I said, well, it probably would be okay, but man, if something happens, you're on very thin ice. You don't really have a leg to stand on. So for now, until I guess more studies or more research has come out, I would not recommend putting it in somebody who's had previous gastric or esophageal surgery. One other thing is if they have a large hiatal hernia, and I learned this the hard way. I had a little bit of experience with the bib balloon. I was part of one of the trials where we were doing the feasibility study, and we didn't necessarily know all this. And so I put a balloon in somebody who had a pretty significant hiatal hernia. I'd say probably a 2 or 3 centimeter hiatal hernia. When I looked in there wasn't a whole lot of esophagitis. Man, you talk about, so all these patients have symptoms. I'll touch on those in a second. But if you put one of these in somebody who has a big hiatal hernia, their symptoms, or at least in my N=1 series, are magnified about 10 times. It's really a miserable experience for them. And of course, they can't have a contraindication endoscopy or any kind of, and you shouldn't have any kind of inflammatory dysmotility problems of the upper GI tract. So to put it in, the first thing you do, bring it to endoscopy, or your surgery center or whatever, wherever you choose to do it. And that's one of the things that you'll have to decide when you're putting together a program. If you do these, are you going to put it in a surgery center? Are you going to be the man or woman who's manning all the anesthesia? Are you going to be in charge of all that? Because for 15 years I did endoscopy with a little bit of conscious sedation and did fine, but about 5 years ago we kind of switched, and almost everybody is using, or at least in my area, has an anesthesiologist with propofol, and to be honest, at first I didn't really care too much for it because it's another hoop to jump through to get your case done, but with these cases it's not so bad. It's certainly an added cost. They're standing at the end of the line or at the front of the line with their hand open, and they want to be paid. But on the other hand, when you're taking one of these out, you have a tedious airway. It's very nice to have them around. Once you put your scope in, you make sure they don't have any esophagitis, ulcer, or hiatal hernia. And this is another kind of thing that I learned. So typically what's going to happen, insurance doesn't cover this. These patients are going to write a check and say, okay, put this in me. You take the check, take them to endoscopy, put the scope down, they have a giant hiatal hernia. Well, now you've got a problem because you should not put it in, so they've got a paraesophageal or 5-centimeter hiatal hernia they didn't know about. And a lot more people than you think, I think, in my opinion, have one. So then you got to stop, you can't do it. Now they've got an endoscopy that everybody wants to get paid for. What we've done is send it to the insurance company, and all except one, we've had good success with that because not all insurance companies will require pre-approval for endoscopy. In fact, most of them don't. So that's just kind of one of the pitfalls you might run into. Once you've confirmed they don't have any contraindications, you lubricate it up and pass it just like you would an orogastric tube. It goes down very easily. You then come in, make sure it's in the right place, and you blow it up. And the fill volume of the Orbera is between 400 and 700 cc's, and I think I use about 600 cc's. So a couple trends that people are talking about. Should you use methylene blue? And this is another controversy. It's my understanding that the Reshape, they give methylene blue in the packet, and so you just put it in. It's nice because one of the complications is spontaneous deflation. That's very unusual, but it can happen. If you have methylene blue in there, then when it happens, the patients, go to the bathroom and pee green, and they call you up and say, hey, it deflated, and then it's up to you to decide. You can go in and retrieve it real quick if it happened, an hour ago, or you can. Some people advocate giving them once it's passed through the pylorus, giving them some things like Go Lightly or something like that to help kind of move it on through. If it gets stuck, it'll get stuck in the at the ileocecal valve. So that's fine with the Reshape. With the Orbera, this is not part of the thing. So this is, believe it or not, an off-label use of methylene blue. You think, what could possibly go wrong? And it would be very unusual for something to go wrong. However, one of the kind of serious complications was I call it quote-unquote band infection. But basically the fluid inside the balloon, I said band, but inside the balloon, sorry, it was basically like a agar medium, and it just started growing bacteria and started growing yeast, actually. And so you had to take this big yeast ball out, and that wasn't real good. And for whatever reason, you wouldn't think a contained yeast ball inside that would cause more symptoms than just a regular balloon, but it did. One other thing that programs are using are fitness integration. Everybody's got these Fitbits that they wear around, or Apple Watches or so forth. Some programs are giving scales that the doctor or nutritionist or whatever can monitor on the Fitbit and seeing how much exercise they're doing. And that's would be really helpful. And in fact, I don't know if Tommy said it, but I think the Reshape, they include it with the program. If you have one take-home message, I think, is that removal is more difficult than placement. Placement's easy. Removal is generally easy, but it can be quite dicey because, first of all, it requires a clean stomach. And I do something a little bit controversial is I tell the patients, one thing that you shouldn't have for this 6 months is any kind of liquid calories. But on the night before, I want you to have a Coke, a regular Coke, and then after that, nothing. So for 24 hours prior to removal, liquids, clear liquids, except for that one Coke the night before. And any of y'all have ever had a G-tube plugged or a J-tube clog that have problems. You know that good old Coca-Cola it'll take the, shine up a penny, it'll break down all the gras doux and so forth, but it also will clean out the stomach. And it does make it easier, because you don't want to be pulling one of these balloons out when it's covered with particulate matter, because that's really a formula for aspiration. The other thing is, when you take it out, one puncture, because when you puncture it one time, and then you have kind of it's almost like a vacuum or watertight seal, and you can pull the fluid out. If you puncture it a couple times, you'll never get it completely compressed down. You want it to almost be like one of those things that you put in the kitchen, where you take all the air, you suck all the air out of it, and put it in a bag. It's almost like freeze drying it, I guess. But you want it to be as small as possible when you pull it down. There are three little, and you grab it with a grasper, or you can use a snare. There's tools that are specially designed to remove it. But there's three stopping points: the LES, the trachea, and the epiglottis. And obviously, what you don't want to do is have the grasper drop it right in the back of the throat and compromise an airway. And for that reason, before you ever remove one, make sure you have some McGill forceps there, because that will help you get it out. And again, that's why it's nice to have anesthesia there. The results, they kind of mirror what Jaime said about the reshaped balloon, but the average weight loss at 6 months is 38% excess body weight loss, and more than 70% of the loss at 6 months is maintained at 12 months, which, I think the obvious answer is that when you take the balloons out, the patients are going to regain some weight. And the only thing that can be more helpful, the only thing that can stop that is if they simply change their eating habits. And hopefully they have. Almost all patients will have nausea, but only about 5% will have the balloon removed early in the U.S. trial. So officially 33% nausea and vomiting. Let me tell you, all of them have it. I've never put a balloon in somebody, they didn't come back the next day and said, man, this is awful. And I do see them the next day, because I think sometimes they get so dehydrated you need to send them to an infusion center or send them to the hospital. Perforation is certainly what we fear the most. It's very unusual, but again, as I mentioned earlier, 50% of the patients who have had perforation were people who had prior gastric surgery. Airway compromise during removal is the nightmare. I've only had one where we got a little bit shaky, but fortunately I had all hands on deck and we were able to get it out very, very quickly without any problem. Spontaneous deflation and migration is about 1 in 100, or I guess 1 in about 70. But of that 1 in the 70, probably about 70% of those will go ahead and pass on through. So it is unusual that you'll have to do a laparoscopy or a laparotomy to remove it. There were 4 deaths reported in the literature that I could see, and they're both 2 of them to airway problems, and 1 due to an airway problem and 3 due to viscous perforation. So this just comes from the slides we show the patients. How long does it stay in? 6 months. One thing that we do is we take all their money up front and say, listen, the way this is you're paying us the money. This is for placement and removals free. And it took us a while to kind of come to that as a philosophy. What you don't want is saying, well, it's 6 months now, it's time to come out. You owe us another, $1,500. Well, I don't have it. Well, it needs to come out, because if it stays in a long time, bad things will happen. It is not designed to stay in more than 6 months. I've seen them in a year without any complications. I've also seen, many of you have seen an internet video of one that was in, I think, a year and a half, and it basically caused necrosis of the stomach. No incisions. How much does it cost? In Louisville, Kentucky, which is not a booming metropolis, it's $7,200, and that puts us kind of in the middle of the different people who are different surgeons who are putting in as far as cost. I talked about the contraindications, who can and can't have one. 2 balloons available currently in the U.S. It doesn't hurt. It can get infected, we talked about. And the one over, everybody raised their hand. Can I have it today? I'm ready for it. You don't want to do that. You want to let them think about it for a while. And I guess the last slide was, first thing that I would do is I would hang crepe. If you're not familiar with that term, it just simply means make it a lot worse than it's going to be. A lot of doctors will do that, say, oh, there's no chance of you pulling through this, and then you pull through it, and everybody feels great, and the doctor feels good and feels better about himself. That's not the reason to hang crepe on these patients. The reason to hang crepe is that you cannot underestimate how bad they're going to feel. I've had a lot of patients who had balloons and then went on to bands or bypasses, and all of them said, man, hand over fist, the surgery is a lot easier to have than one of these. So it's not super easy to have. You have to juggle the antispasmodics and antiemetics and H2 blockers. If somebody says, all right, I've had enough, I want it out, you can say, well, now let's just work on it a little bit. You can maybe give them hold them off just a bit. But if they say, I want it out, take it out, even if it's day 2. Because you don't know, one of the problems is, you know, when you're talking about perforation and Boerhaav's and that type of thing from vomiting, you don't know if it's because they're just not tolerating it or if they're really having a problem. There's no red flag, no thing that they can tell you, no catchphrase to say, hey, I need to take it out. If they want it out, take it out. You have to decide about methylene blue. The reason I say, you say what could possibly go wrong, but if you happen to put in methylene blue and they get one of these fungus balls or whatever you want to call it, then, you know, maybe they say it's because, you know, you contaminate it with the methylene blue or you contaminate it when you were injecting something that's not, you know, approved for use. I think it's a great thing to give them a Coke. It's something that they laugh about, and it also reminds them not to have any sugary or watery drinks or sugary or caloric drinks until time for removal. And then be proactive in the financial policy. Like, I think that our lawyers came to us and said, here's how you got to do it. You know, the removal is going to be free. And I think that really worked well for us, and I think it's good. And what are you going to do? You have to have a policy in place, EGD with a large, if you do an EGD and they have a large hiatal hernia. So how are you going to handle that? Sorry I went a little bit over. Thank you very much for your time. Oh, I have no, it was the first one, no disclosures.